Welcome to the Medical Collective, your go-to podcast where medicine meets real life. I'm Dr. Keisha Davis, a pathologist, personal trainer, and your host. I will be joined by a vibrant team of doctors who are not just healthcare professionals, but artists, fitness enthusiasts, and advocates for change. Each episode, we dive deep into the world of medicine, from untold stories of the healthcare industry to the latest in medical advancements. We're here to bring your insights, answer your burning questions, and explore the art and science of healing. So let's get started and step into the world of the Medical Collective. Hello, everybody. Welcome back. I am Dr. Keisha, your host of the Medical Collective, and I'm so excited because it is Breast Cancer Awareness Month. We have a lot to get into. I promised we would have the discussion, and we're going to have it today. And we have a special guest, Dr. Islamiat. So we're going to start by introducing Dr. Islamiat. I got Dr. Sharon with me, so all today is about breast cancer diagnosis, but let's meet her first. Hello, Dr. Islamiat.
Hi, thanks for having me. It's good to be here. My name is Dr. Islamiat Ego-Osuala. I am a breast imaging radiologist in the DC, Maryland, and Virginia tri-state area. I work with a private practice group called Washington Radiology, and I am a breast imaging specialist radiologist, actually.
I mean, it's not every day you normally have a specialist that's a breast radiologist. I probably shared with you guys, my father is a retired radiologist, but you specialize specifically in breast radiology. So we're going to get into that today, but we have a couple of news stories. And the first one is, I literally just picked this up. It's about an antidepressant that's been recalled. For those that know, it's under the category of SSRI. And this one is sertraline. It usually has a more common name, but the important thing is that there are several lots. And if you go to FDA website, they're really good at putting out the lots. And you also can talk to your doctor. But there are several lots that are contaminated with something called NDMA. And this substance is a potential carcinogen, but the problem is it shouldn't be in these lots. So check to see if you have a lot number that's part of the recall. Consult with your doctor and speak to them about it, as well as you can call your pharmacist and then discuss alternatives. But it is recommended not to stop your medication right away. Consult your physician first. Any comments on that one?
No, I just think if anyone have any questions, they can contact their physician, and you can actually even contact the pharmacy that you picked up your medication from also. So that will be another good resource.
I agree as well. I think that these medications are very, very sensitive in terms of their doses. And I think you already mentioned the most important part is just do not stop taking them. Contact your doctor before you take any or make any moves to address that issue.
So our next story actually is around mammograms. We're going to get into the breast cancer diagnosis and screening in a minute. But this story, Dr. Islamiat, is for you. This is an article that's talking about the use of mammogram not only for screening and diagnosing breast cancer, but for cardiovascular disease. According to the Journal of American College of Cardiology, they're suggesting that mammograms can be used not only for breast cancer screening, but for calcifications in the arteries around the breast that can help with cardiovascular disease screening. So this is very interesting and exciting. I know we hear the word calcifications in breast, but we're looking for these in the artery. So have you heard about this article, and what are your feelings?
Absolutely. This is actually something that has been up and coming in the field of breast radiology. So breast arterial calcifications are actually not new. There are known incidental findings that for the longest time we've been trained to ignore, but there's been more and more research recently to show that there is some kind of association with cardiovascular risk. And this is a great opportunity because a lot of women, this is like a one-stop shop to get two things taken care of, right? Breast cancer screening, and as well as possibly assess for cardiovascular risk. A lot of young women that have no family history, they don't get regular cardiovascular screening or risk stratification. So, this is kind of like a warning sign to cardiovascular risk. And if we can give them that information to act on it, then we should.
I love it, and I agree. So stay tuned, everyone, for that. Listen, this next one, Dr. Sharon, we just heard about. We have been talking about the election and understanding healthcare around that. But this is important because what Biden administration has just done is they proposed to cover contraceptives within the Affordable Care Act. So they want to enhance your insurance coverage. So getting over-the-counter contraceptives will be possible without having to pay anything at all, which is very exciting. Now, listen, it does still have to be passed through Congress for this to come into enactment, and there may be some changes to it as well. So, Dr. Sharon, how do you feel about this? About time, right?
Yes, I'm excited about this, especially in light of the overthrow of Roe versus Wade, taking away that federal protection for women. And especially in states like where I am in Texas, where we have such a strict abortion ban and our hands are being tied and women are dying. I think this also does really help so that we can broaden the coverage and basically the availability for birth control, different option of contraception for patients.
I agree. Such great news. So be looking forward to that to see when that is passed. Last one of our news is about E. coli. Now, Dr. Sharon and Dr. Islamiat, I know you guys are like me. McDonald's, what? Like we don't go to fast food chains. But listen, one of these Big Macs that people consume has now had an E. coli break. Like how many times we hear about these a lot, right? This most recent one has contaminated ground beef in a specific type of patty, which I don't even know what it is. But listen, E. coli infections can be very severe. And this one has actually already claimed one life, and over 50 have been infected in multiple states. So be on the lookout for that. I don't know if you guys want to talk about some of the signs and symptoms of E. coli, but again, when you're eating foodborne illnesses are real, and when you're going out to eat them, they can travel fast, far, and wide.
I'm not a fast food eater at all. I'm just not. I tend to eat on the cleaner side. And I mean, food safety, especially in the fast food industry, is definitely always a concern. But anyone who's had McDonald's and have any form of symptoms for E. coli is usually like nausea, vomiting, diarrhea, fevers, chills also can be part of that. Bloody stools also. You definitely need to proceed to the nearest emergency room so that you can get treatment, because this can be deadly. I mean, already one person already died, which is to me one too much. But my advice to anyone is to stay away from the murder burgers. That's it.
They're called murder burgers?
That's what I call them. Yes, ma'am.
I'm with you, because if not, you're going to have a mammogram looking for calcifications in your artery by Dr. Islamiat, right?
Exactly.
Good point.
Very good point. And there is a serotype of E. coli, let me put on my little pathology hat, that does cause these severe symptoms, and they're called hemolytic uremic syndrome. And that is real, can happen. You don't know which one is infecting you. And I will play devil's advocate, because sometimes salad products can be contaminated with E. coli. We've seen that as well. So just be cautious of all things, but stay away from the murder burger. For sure. Okay, so now we're going to get into breast cancer diagnosis. Like, I'm so excited. For those who don't know, we literally have the dream team of which you would see the progression from having your obstetrician gynecologist looking at you, giving you an examination, to going to radiology to have that screening or diagnostic mammogram or ultrasound or MRI, and then having a pathologist who's looking at it under the microscope. So anything you want right here, this is what you see. Some you don't see, some you do see. So the first part that we're going to get into is about the screening methods, Dr. Islamiat. Just quickly before we get to, and Dr. Sharon as well, because screening can take places in multiple ways. And you can throw in here at this time, Dr. Sharon, about the screening or the self-breast exam and what's going on with that. But the screening is very, very important from the time you as an individual are looking at and examining your breast tissue to the time you go to Dr. Sharon, whether it's for an annual or because you're concerned, or then you're getting your screening mammogram. So we'll start with you, Dr. Sharon, and then go to Dr. Islamiat about the screening methods that you use, and then you as well, Dr. Islamiat.
Patient will typically present to me in different ways. Sometimes it's someone who's coming in for their annual exam, and I usually go over their history, their physical. Part of that is a complete breast exam, and if I palpate anything or suspicious of anything, I'll send them for the appropriate screening. Or the second scenario is a patient will present to me with a concern, saying that they felt a mass or something unusual, something that wasn't there previously. Again, history and physical is where I usually start. Do the breast exam, complete history of, when did they feel that mass, onset, location, duration, and also with that, and always too also will be the family history of any cancers. And then from there, I will send them on to the radiologist for, it's actually at that point when you come in with a complaint, or if someone presents to me with just for a well-woman exam and I palpate a mass, it's actually no longer a screening exam, right? So what I check is I check diagnostic workup. So I don't cherry pick, ultrasound, MRI, nothing. I say diagnostic exam. So then the radiologist will have free reign to do what the patient needs, right? Because if I don't do that, then they're going to be calling me back, the day of, the day after. Hey, can you send in an order? She now needs an ultrasound. Oh, can you send it? And what that does is really truly delay the care of the patient. So I don't do that. Just click off diagnostic workup, and so let the radiologist do their job.
Great. Now, Dr. Sharon, what if a patient comes in and feels something at home? I'm sure you're still seeing that. And would you tell your patients, because now recommendations are coming out that self-breast exams are not recommended?
I would never tell a patient not to examine themselves, right?
Yes.
I've had numerous patients who have come to me who felt a mass that wasn't there previously. Actually, one of my good friends were recently diagnosed with breast cancer early this year, and her mammogram last September was negative. And she called me one night telling me that she felt a mass. And then, went through the whole diagnosis, mammogram, biopsy and everything. And it turned out to be a breast cancer when she had a negative mammogram last September. However, she felt a mass this year. And luckily, she'd been doing self-exams. Because then if she wasn't, then God knows if you would have gone back in time for your repeat mammogram, and then maybe they would have seen it then. But no, I think patients should take responsibility for their bodies and do that self-breast exam monthly. If you are still a menstruating woman, I would recommend 1 week or so after your cycles. If you're a postmenopausal woman, then I would just probably recommend like one particular week out of the month. I'll just do it as much as you want to. That's, to your body. So you really need to be in tune with it.
I completely agree as well. Patients ask me all the time, like, should I do self-breast exams? And I always tell them emphatically, yes.
Right.
The reason is, you want to know what is normal for you. You want to be able to tell what your breast feels like on, at any given time, because that's really the best way to tell when something is wrong. And this is even more important for women that are not getting mammograms yet, or younger women. The way most of them pick up any kind of abnormality is by self-breast exams. They feel something. So I think it should truly be encouraged that, self-breast exams are important. It's a way to learn what is normal for you so that you can tell when something is abnormal.
True. And so after the examination, there's a screening part and there's the diagnostic part. But when we talk about the screening part, Dr. Islamiat, there's still a lot of conversation around when should I get my mammogram and the difference between when I get a mammogram versus an ultrasound versus an MRI. So maybe you can describe a little bit about that.
Yeah, so that's a pretty meaty question, but I'll try to address it as. So, okay, first, I think we should talk about what the difference is between screening and diagnostic mammograms. So, a screening mammogram basically means that you're coming in with no symptoms whatsoever. This is just your regular annual exam just to see how you're doing. And then the diagnostic is when you have a symptom or maybe you feel something, your doctor felt something, whether it's a lump or a discharge or skin thickening or swollen lymph nodes. There are so many ways that, you can have problems. So that you come in with a diagnostic order. And the thing with a diagnostic mammogram is that you will be getting your imaging in real time with a radiologist on site. So they will look at your mammogram once it's done. And then if there's any additional imaging needed, they can acquire those additional imaging while you're still there. With screening, you tend to get the mammogram and then you go home and get a letter in the mail. In terms of when to start screening, when we're talking about initiation of mammograms, first we have to talk about risk. If you are an average risk woman, we recommend, we being the American College of Radiology, the Society of Breast Imaging, we recommend that you start your annual screening mammogram at age 40. But if you are considered high risk, and the way you can determine your risk is by having a genetic risk assessment with your provider, we recommend that you get this by age 25. And what that entails is that they would use your history, your family history, and some other factors to see if you're considered high risk for breast cancer. If you're high risk, then you might need to start sooner than 40 years old. So the first step is first get a genetic risk assessment with your primary care doctor, preferably by age 25. If you're determined to be high risk, you need to start before 40. The rule of thumb is usually 10 years before your first degree relative. If you're average risk, then you need to start at age 40. And there are some other people that maybe have genetic mutations that might even start at 30.
Okay, great. And so the diagnostic would mean when there is an actual concern for a lesion or something's found on the mammogram, correct? So let's kind of go through that, because the understanding the difference between the mammogram, the ultrasound, because I still hear this even from family members. They're like, okay, I have to get a mammogram and an ultrasound, but no, I have to get an MRI. So maybe just briefly summarizing, like when diagnostic is happening, when you would get a diagnostic mammogram, an MRI, or an ultrasound.
So we always, if we can help it, we always start with mammogram. There are a few instances that we will start with an ultrasound, maybe because of age is the most common reason why we would start with ultrasound. But for any patient that is symptomatic, we would start with a mammogram. That is the gold standard in terms of breast cancer screening and diagnosis. If we do find something on mammogram, such as a mass that we need to characterize better, then we would move on to the ultrasound. The ultrasound would then give us a detail whether this is a cyst, meaning a fluid-filled entity, or if this is a solid mass. And then from that, we will be able to tell what we need to do, whether to say this is benign, you can go home, or this is a mass that looks suspicious, we need to biopsy, or this is a mass that looks like it's probably benign, I'll see you back in 6 months. So usually those are the common steps in a diagnostic setting. MRI comes on later on for other things, such as supplemental screening, which we can talk about later on in terms of breast density and risk factors.
And, I will talk a little bit about when pathology comes into play, because after a diagnostic mammogram and there's something that is believed to be biopsied, the radiologist will biopsy it in those modalities, and they're actually getting small slithers, like small fingernail slithers of tissue. But with my microscope, I can see a lot. and we're making a diagnosis. Now, the majority of actual breast biopsies that we see are usually benign lesions. Benign lesions can grow and make something that's a mass, or I mentioned before when we were talking about calcifications, they can, just because they're moving around, cause densities or calcification. So there's different reasons why you have calcifications, and we're going to find out in the microscope after we get the tissue, after we process it, after it's put on a slide for me. In all breast cases at most institutions are looked at by 2 pathologists to make sure, even if it's benign, that whether it's a fibroadenoma, whether it's a papilloma or cancer, to make sure that we're making the correct diagnosis and not missing anything. So there's a lot that goes into it. I'll get a little bit into that later. But I have a couple of questions for you all. This is like the question round, I should say, because I think it's important to talk about a couple of things. And one of them is about the mammogram and the pain. A lot of what I hear is, I don't want to get that. I'm scared. It's so painful. So I'm sure you all hear that. So what's like the answer you could say to those people like, I don't want to get it. It's too uncomfortable. I'm sure you hear it, Dr. Sharon.
Yes, I do. I hear it a lot.
They're going to squeeze it. They're going to squeeze it so hard.
Yeah. So what I say to my patient is that it's not the most comfortable thing, right? However, that momentary discomfort is worth an early diagnosis.
Yes.
That's it. That momentary where they're squeezing and I got to hold my breath and, for the imaging, it's really minor in terms of diagnosis and treatment for breast cancer. Especially with breast cancer treatment, it's a journey. Typically, it is a long journey because typically it may involve surgery, chemo, rounds of chemo, radiation, reconstructive surgery. So you can spend a whole year plus going through treatment for breast cancer. Whereas if you're going to get a mammogram, the radiologist is there on site. And, that whatever time you spend with, doing the actual mammogram and ultrasounds or whatever diagnostic study, that minor discomfort is so worth an early diagnosis or to know if you need to follow up in 3 months, 6 months. It gives you a lot of information. So, you're not talking to a man who don't really get mammogram. You're talking to women who get regular mammograms. So please, ladies, I'm begging you, go get your mammograms. That momentary discomfort is worth that early diagnosis.
I love it, Dr. Sharon. Dr. Islamiat?
I completely agree. And I love the way Dr. Sharon said it. It's really, honestly, a momentary discomfort. I had a mammogram recently, and I was also actually very scared because of the pain. It's so funny because I do this on a daily basis. And then being on the other side of it, I'm like, oh my God, I don't know. But I look, from experience, it really is a transient discomfort. If you're really, truly worried about the pain as a premenopausal woman, just go when you're least tender. Like Dr. Sharon said, like a week after your menstrual cycle, you can time it to that. If anything, you can also take like Tylenol before if you're really worried about that discomfort. But honestly, a lot of patients that get their mammograms, they come in thinking it's going to be very painful, and they come out of it like, oh, it wasn't that bad. And I'm like, see? And I try to tell them, like, I've been through it as well. Thousands and thousands and hundreds of thousands and millions of women have done this. So if all of them can do it, you can do it as well. So, yeah.
I love that. Okay, this other question is funny to me because it's still happening. And it's as if you're going to a place and they're asking you, do you want regular class or do you want first class? Like, yeah, I want the first class. And then they tell you, well, it's going to be $300 more. And you're like, never mind. What is the difference between 2D and 3D? And why are places still asking people if they want it? Because if they don't understand the importance of 3D, especially in dense breast tissue, they're going to be like, once they say, oh, insurance doesn't cover it, which is crazy that they're still being told that at some places. Yeah, I've had an issue with that before. They ask you, do you want 3D? It shouldn't be a question. but people are like, oh, 3D, that sounds neat. So explain the difference between 2D and 3D and how, at this point, basically, insurance should be covering 3D.
Yeah, I'm surprised by that because 2D used to be our gold standard for mammograms. It's basically a two-dimensional image, but 3D is what we use now. Most places that should be what they should be using, and it is covered by insurance. Especially with the Affordable Care Act, it should be covered. 3D, I think of it as think of having a loaf of bread. You can't see what is inside. You can only see like the outside. But 3D is like sliced bread, right? You can flip through each slice and then see what is inside. So it gives us better visualization, particularly in women that have dense breasts. So the problem with dense breasts is that, mammograms are black and white images. They're X-rays. Dense breast is basically the composition or the amount of the fibrous and glandular elements that you have, which looks white on mammogram. And then there's also fat, which looks black. The problem with density is the more fibroglandular elements you have, the more dense you are. And cancer is white. So white on white is hard to see. Think about putting, I've seen this before somewhere where somebody put marshmallow in a cup of milk, in a cup of white, it's really hard to see. So being able to go through each slice gives us better visualization, particularly if there's some kind of small cancer hiding there. So that's basically, what the difference is between the 2D and 3D. The 2D is like the loaf of bread, and then 3D is like a sliced bread.
Yeah. And a lot of people actually, that's a good follow-up, have questions about what is, dense breast tissue. And as one person that has it and that's high risk, in pathology, it's very similar that the dense breast tissue that we get for mastectomies is more difficult to sift through and actually find a lesion. And it's just that you have more of the white fibrous tissue, less fat. And so we always do actually give an estimate of the fat to fibrous or fibrous to fat ratio, so that people can understand that. But that's a good way of explaining it. Okay, here's another one. Are there lifestyle changes that can help reduce my breast cancer risk?
Absolutely. When we talk about breast cancer risk, we talk about modifiable and non-modifiable risk factors. Non-modifiable being the fact that we're female and aging. Those are the two biggest ones. But things that we can do that can help our risk, first of course, it's exercise. And I feel like it's not just breast cancer that helps. It helps all the other kinds of cancers as well. Our diets, it's been shown that a more plant-based diet is very, very favorable in terms of breast cancer risk. So, more of the Mediterranean diet, it's good, less red meat, less processed meat, things of that nature. Also trying to stay away from any kind of like environmental toxins. So for a lot of Black women, hair relaxers, they're known to have endocrine disruptors that can also kind of mess up that balance of estrogen and also like hormones in our body and can increase your risk for breast cancer. So those are the biggest things. Drinking is alcohol. Drinking is another one. We don't know what the particular amount is that is the cutoff, but we try to say, if you really truly have to drink, try not to exceed like 3 glasses a week, right? So if you can cut it off entirely, wonderful. But if you really feel like you need to celebrate and have a good time with your friends, try not to exceed like 3 glasses a week.
Great. Dr. Sharon?
Yes, another big factor that contributes to cancer, breast cancer, and many other cancers, actually obesity. Mm-hmm. Yeah, patients with obesity have a higher risk of breast cancer, and also patients with obesity don't present to the physician. They don't present for care just because of biases and against patients with obesity. So when they present late. That's one factor. And the diagnosis itself, is a little bit more difficult in patients with with obesity. And the obesity itself increase that risk of breast cancer and other cancers. So I think that would be the one thing that I would add.
That's great.
Yeah.
So it really lets you know that the majority of breast cancers, or many, can be mitigated by preventable risk factors and how you deal with that. But I will say, there are hereditary, there are genetic links, but 85% of breast cancers occur in those with no family history. So that's something to take into account. And next time we will talk with a genetics counselor about genetics and cancer. So stay tuned for that. One last one is about treatment options. And we'll briefly talk about this. The question would be, what are the options if I have a lump? What are my treatment options? And I would say this is where the art of medicine comes into play. No two people, first of all, no two lesions or cancers are the same, and no two people may need the same treatment. It's dependent on so many different things. So whether the treatment option is to watch and see with someone that has a papilloma versus someone that has a cancer, and they're going to decide versus taking out what we call an excisional or a lumpectomy versus a mastectomy versus other treatment options, it's really dependent on the person. So, radiation, chemo, all of those things are really dependent on what your tumor is and then what we see under the microscope. That's when the pathologic diagnosis includes not just looking under the microscope, but we will do, if it's cancer, we will do not just the ER, PR, and HER2/neu that you guys may hear, or what is called a triple negative cancer, if it doesn't have any of those. But there's also some other biomarkers that we can do in addition, depending on the stage. We'll also say how big it is, the grade of the tumor, the type of the tumor. All of those things take into play onto the treatment options. Anything you all wanted to add about that?
Yeah, and I think the biggest driver of that is also early detection, right? The treatment options you have become more and more extensive the later you get diagnosed. But if you have early diagnosis, early detection, usually it leads to a less extensive treatment and care in general. So, and I guess this is why it's so important to get your mammograms, because frankly, most breast cancers present with no symptoms, nothing at all, and, you just come in for your screening mammogram, they detect something, and then you go from there. So don't wait till you feel something, see something before you're coming for your mammogram. Make sure you get your screening mammogram when you're due to.
Yeah, because screening can reduce breast cancer mortality by up to 40% in women. So please heed us. As Dr. Sharon said, get your mammogram. Please get your mammogram. Okay, 2 more sections. One quickly, what about males too? This week is actually Male Breast Cancer Awareness Week within the month of breast cancer awareness. And men are not immune. I always share the story about one of the most difficult and hardest cases that I saw was in a male breast cancer, because the individual did have a large lesion but presented at a late stage with back pain. So it wasn't the chest mass that was his complaint, but it was the back lesion. So, even though it's rare, it accounts probably for 1% of all breast cancers, male breast cancers do. There are still risk factors, including some of the genetic that we haven't talked about, but will in the next episode, like BRCA2 mutations, Klinefelter syndrome, and other family history syndromes. But it's really important, I think, in men, that's when, since there's no screening for men, to really know what's going on with your chest, your body, any lumps anywhere, instead of waiting until it's too late. Any thoughts on that?
I do agree. And it's definitely because male breast cancer tend to be diagnosed a little bit later. I think, and especially as we get older, you just have to give yourself a one-over, every couple of months or so, just to, just double check. And especially with male breast cancer with no screening, because I've seen breast cancer in male, and typically is diagnosed later. And it can be devastating just because of that late diagnosis alone.
I agree. And one quick thing before I throw it to Dr. Islamiat, really a lot of it's about reducing the stigma. We know Beyonce's father came out years ago as, talking about his journey through it. But for men to think, oh, I know I don't have breasts. But I always describe it as like a stick balloon. Like back in the day, you have the stick balloons. The men still do have the ducts. They just don't have the lobular, the end unit. And so you can still, because you have those ducts, you still have glandular elements, you still can have cancer, that whether we have to call it chest cancer, whatever we have to do, there shouldn't be a stigma on it that there's maybe about being embarrassed of having it. And I don't know if you see that, Dr. Islamiat, when you do have to do diagnostic mammograms or other imaging on males.
Yeah. And I mean, absolutely. Just like with women, if a male presents with a lump, we start with a mammogram as well. And I try to kind of downplay it to them, like, oh, you see how it feels to be a woman. And, it kind of breaks the ice a little bit when you're seeing males. But honestly, there is nothing to be ashamed about. In addition to the stigmatization, there is also, I know there's a distrust of the healthcare system historically, particularly in people of color. But I just want to encourage us that, whenever you feel something and something is different, it's just not worth it. It's just better to come in and get all the stuff done. A lot of things are more common than people know. I see males with lumps actually pretty often, at least maybe once or twice a week. So if you're a male that feels something or knows something is different, don't think that you're alone or you're the only person that is weird or anything like that. This is something that is well known and it's highly treatable if it's caught early. And the reason why males are not doing better, as you both precluded to, is because we're catching this at later stages because some males do not want to show up for the imaging because they're shy or they're embarrassed by it. But it's nothing to be embarrassed by. And this is not just for male breast cancer. This is just healthcare in general for our men. We need to make sure we address things in a timely fashion.
I agree. As we round out kind of, we look at male breast cancer in women, we're diagnosing more, but that's good. More people are surviving. The horizon is exciting because and Dr. Sharon knows I love AI, not just generative AI, but what it's doing in the diagnostic field, pathology and radiology. So, in your field, Dr. Islamiat, I'm sure they're on the horizon, AI techniques that are being used and will be used to help assist in diagnosing cancer and tumors. Maybe not just breast, but if you could talk about how AI in the future is going to help improve detection, and then any ongoing research that's happening with mammograms.
Yeah, I think that AI has so many pockets it can get inserted into, particularly with imaging. With respect to breast imaging, I feel like it's just amazing because we all know that there is a shortage of physicians, but the patient load is increasing. So we need to find more efficient ways of doing things, right? So if AI can help us kind of go through our mammograms faster, but without losing the accuracy, then that's a great thing. At least in our practice, we're using AI, one, to help us standardize how we report density. So that way, if your patient really has dense breasts, they can get supplemental imaging, preferably with MRI and some people with ultrasound. We're using AI in terms of also for detecting breast arterial calcifications, actually. There's a lot of research coming out about how software related to that can help us pick up breast arterial calcifications. Because like I said, breast radiologists have been trained to kind of ignore that particular finding because it has nothing to do with breast cancer. But now they want us to report it. So having that little assistance is great. Some people are using AI to help them kind of sort out their work, to try to help them kind of prioritize which patients would need to be read quicker versus the ones that can wait a little bit longer. And there's some that are also trying to help us draw attention to particular lesions on mammograms, whether they're calcifications. So these particular ones are used for they're helping with enhanced detection. So there are so many pockets that, the softwares are helping us. And I think, the sky is the limit with that. And I can't wait to see how it continues to evolve.
Listed me as well because in pathology, I actually helped in a couple companies with reading and trying to circle the cells to feed the machine. And it's amazing because a lot of them were very, very close. And these are techniques that would help circle the tumor cells, be able to grade the tumor cells, and even measure the amount of tumor. And imagine how that would help streamline. It's going to catch those things that may be difficult to help us to improve. And then in addition, as we use biomarkers and other things to help, it can guide us to say this would help with the treatment for this patient's tumor, right? Instead of just what we normally think are the standardized treatment. So it's exciting. It definitely is. Some other little hot things to close with, Dr. Sharon, is some of the debates. And as we end this election and as we think about people with breast cancer, we think, okay, you go, now you have breast cancer, everything's going to be covered, everything's great. And there still are issues, right? Sometimes having to get certain tests covered by insurance, certain supplemental screenings may not be covered by insurance, or having to jump through hoops, you literally to deal with that. So, what are your words or thoughts on what's going on with insurance coverage and what you would hope that would improve in the future? Because I think AI actually is trying to sometimes help with getting some of that filed, maybe.
For me, one of the biggest things that I see is that even with private insurance coverage or so, some of the deductibles are quite high. Right? So people have out-of-pocket costs of, thousands of dollars that the insurance don't cover. You're responsible for that. And a lot of people may not be able to afford that, right? Last year I had a diagnostic mammogram with an ultrasound, and the ultrasound for me, out of pocket, was like $700. And I was like, really? So just think about that. And that's just diagnosis. Imagine treatment, right? So especially if you have like a huge deductible. So let's say, and it's now October, November. Let's say someone gets diagnosed with cancer at the end of the year. Now you have this, and you have not even met your deductible. So let's say you have like a $7,000 deductible. Then you got to pay that, right? And then for some insurance companies, the deductible resets January. So then you have a $5,000 deductible that you got to be meet by the end of this year. And then starting January, you have that $5,000 deductible again, or whatever your deductible is, right? And that poses a big hardship for people, especially the middle class, right? So I'm hoping somewhere, somehow, that would be able to bridge that gap, right? Medical expenses is actually the number one cause of bankruptcy in this country. Right? So imagine now someone with, that diagnosis, you have this huge insurance gap, you're underinsured, or you can't pay that deductible, right? And that breast cancer treatment goes on for months, a year, before you've done, the diagnosis, the surgery, the rounds of chemotherapy, the radiation that you may need. You may need to see a nutritionist. You may need to see a therapist to deal with the whole psychological trauma of, that. You may need to change your entire eating habit. So it becomes, I definitely see this where it becomes, it can be like a huge financial burden for patients. So it's how are we going to bridge that gap or make your insurance more affordable? Because people pay these high premiums too for lacking coverage, right? So I'm hoping that something can happen with that. That is my hope.
Yeah. And pre-auth. Like, Dr. Sharon, I told you how long it took me to wait to get a pre-authorization for the MRI. And just imagine the frustration. So I take off time and then it doesn't go through. I'm waiting on this. It becomes frustrating to where you just can give up. And imagine if that is something that's literally going to make or break you getting diagnosed with cancer.
I know, which is why it's very important that we support. There are a couple bills that are coming out. I think the first one is the ABCD Act, which is the Access to Breast Care Diagnosis Act. And basically the point of that, bill is to prohibit, group plans and like all the insurance companies from to stop like cost sharing when it comes to diagnostics and supplemental imaging. And I think there's another one called the Find It Early Act, which also is basically the point is to have insurance companies cover supplementary screening, particularly in women with dense breasts. So hopefully those two bills and acts pass, because I feel like that would definitely take away a lot of burden for a lot of patients. Because sometimes that's what really truly delays care. Because if a patient goes through screening, which is covered, they find something, they call to make the appointment, and then they tell them they have a copay or a deductible of $250, $300. In this climate, that's not necessarily what people have the luxury to do. And that becomes something that they really have to wait for their families with. And I don't think that is fair, because, it's just it's not sustainable. Not sustainable. So hopefully we pray that both of this acts pass in the Congress, and, the patients can get what they need.
Yeah. And, it's a food for thought. It's so complex, right? We think we are doing part for patient care, and then not understanding the complexities of everything around it and how politics and the government plays into it as well. So I hope this employs people to really understand and to get into the doctor if you can. If you can, please. And I end with a story I think about of a celebrity who I really appreciate people that share their story, because someone somewhere is listening to that story who now shares her story as she's dealing with stage 4 breast cancer. And she says that, she didn't want to do the mammogram for issues. And I think that's why it's important for you to explain the importance of mammogram and then like the low risks that come with it. But how much the benefits outweigh the risks, because now that she has stage 4 cancer and she decided not to have surgery, she's looking back on it and she's like, I wish I would have done this, but I want to share my platform to tell other people, please get your mammogram. That's what she says. Please get your mammogram no matter what. And, surgery, all the different things together combined are important if needed, and to try to take that into account. So, I think we should listen to the stories of those of others, listen to the stories of your friends, your colleagues, and be accountable. So any thoughts about that, or any final thoughts you would like to share with everyone?
The risk is 1 in 8, which means of our friend circle, our family circle, we will know someone who's had or have breast cancer, right? And what I have been seeing as a OB-GYN is that I tend to see it early. I've seen early, like premenopausal, 30s, who've come to me with stage 4. So I'm saying this to say that self-breast exam monthly is really important. That early diagnosis is important. As we age, the risk of breast cancer increases. The risk of cancer increases as we get older. However, we can help mitigate some of those risks, especially if it's not truly genetic, because then your screening becomes a little bit different with our lifestyle changes. Exercise. Just refraining from ultra-refined foods. Stay away from McDonald's and any other fast foods. You know how I feel about those already. For many reasons. And patients with obesity, there are different treatment options right now that can help reduce that risk for you. So those are some of the things I would give. Oh, and exercise. I'm a big proponent of that physical activity.
Exercise, dance
yes, just
running,
start slow,
swimming.
Start slow, go slow. If you can't get off the couch today, move your legs, move around, move your legs, move your arms. Tomorrow, take a step. The next day, another step. Next day, 2 more steps. And you will get there. But the work starts now to help mitigate that risk, as we age. And that's what I'll add for now.
Thank you, Dr. Sharon.
You're welcome.
Dr. Islamiat, any final
So
thoughts?
For me, just a few final thoughts. First, please get a genetic risk assessment by age 25. That's the first thing I wanted to say. Most people get their risk score using the Tyrer-Cuzick score assessment system. This is the first step in identifying if you need screening earlier or if you're average risk. Number 2, if you're average risk, please get your screening mammogram every year. I cannot stress this enough. There are so many contradicting guidelines out there, but getting your screening mammograms every year has been shown to reduce mortality the most. And starting at 40 has been shown to even have better outcomes compared to if you start at 50, and even better outcomes than if you do it every other year. So every year, please do your screening mammograms. When you do your screening mammogram, please get information about your breast density. Actually, the good thing now is that the FDA just, made it, mandatory for your breast imaging facility to let you know what your breast density is. So it used to be just some states, but now it's actually federal law that we have to let you know what your density is. This is really important. In fact, it's so important that the FDA had to make us do it. And the reason is because mammograms can be limited in people with dense breasts. It can even be only about 30% sensitive in people with dense breasts. And dense breast in itself is an independent risk factor for breast cancer. So know your breast density, because that would in turn tell you if you need supplemental imaging. Most preferably, I tell patients MRI instead of ultrasound. If you're not MRI candidate, then ultrasound. The reason is MRI picks up about 16 more additional cancers per 1,000 women screened, compared to ultrasound, which is about 1 to 2 additional cancers per 1,000 women screened. So you can see that the MRI is a way better test. People talk about false positives when it comes to MRI, but now new research is showing that the false positives on MRI is about the same as the mammogram. So there's no downside to it at this point. It's a win-win situation. A lot of celebrities are coming out that they've had negative mammograms and then they would get an MRI and it would be positive. Another thing I feel like I wanted to mention was be careful about misinformation. This is such a big problem now with social media. Be very careful about who you're listening to. Make sure that you do your own research, because there's a lot of people talk about thermography or mammograms are harmful and things of that nature, and then they come back and retract that statement. While I credit their bravery for coming back to say that I was wrong, there are so many other people that have already been affected by that information. So we all have to be accountable and be very careful about the kind of misinformation that could be out there. Do your research, talk to your primary care providers, and just basically use all the resources that you have in your favor.
Great information, and full transparency, I've had all of those imaging. So there are many people that are going through that. They may have to get their screening done every 6 months, and it's completely normal. Stress and fear are normal things that I go through, but it's so important because for me, I want to know, I want to put a face, a name to whatever's going on in my body, and I can attack it early on. Also, if you ever have questions about a biopsy, you can talk to your doctor and have them explain it to you. PASH is something that I hear a lot, and I had done a post, and a lot of people are like, oh my gosh, I've had that. And it's just like a lesion that's found, and it sounds so interesting or bewilding, but it's just a benign entity that forms a mass and has to get biopsied. So sometimes things sound more, we just put scientific names to them than they are. But if you get things explained to you, I really think sometimes that'll help you and ease some of that anxiety as well. So we talked about a lot today. Thank you, Dr. Sharon. Thank you, Dr. Islamiat. Where can we find you, Dr. Islamiat, for those that want to know? And I'll make sure in the show notes, that I put that information.
Absolutely. So I run an account called the Minority Breast Report on Instagram. So I try to put out as much information as possible. It's difficult having small kids and working full time, but I can definitely be reached on that platform. So yeah.
Great. And if you have any questions, be looking out. Hopefully we'll have Dr. Islamiat back on for more information on the Medical Collective. Thank you, Dr. Sharon, and thank you, audience. Have a great day. Thank you for tuning in to the Medical Collective. We hope today's episode has left you with valuable insights and a new perspective on healthcare. Don't forget, follow us on social media for more updates and behind-the-scenes content. I'm Dr. Keisha Davis, and it's been a pleasure to share this time with you. Stay healthy, stay informed, and we'll see you in the next episode, where medicine continues to meet real life. Please note that the content provided in the Medical Collective podcast, including text, graphics, images, and other material, is for informational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed on this podcast are solely those of the individual authors and guests and do not represent those of the Medical Collective, its staff, and any affiliated entities. The appearance of content on the podcast does not imply an endorsement. Neither the host, Dr. Keisha Davis, the co-host, or any guest of the podcast bear responsibility for the accuracy of the content provided or the use of information received through the podcast. Reliance on any information provided by the Medical Collective podcast